All right, so let's get into it here then. Now with the wrist in the hand here, what is my actual wrist joint? Yeah, it's your radiocarpal joint. And what movements does that make?
Flexion, extension, and radial and ulnar deviation.
Yes. So remember that the radiocarpal joint does not have any transverse plane movement. The transverse movement you have is exclusive to the forearm. So when you do pronation, supination, that is just going to be the forearm itself. So the radial ulnar joint, both proximal and distal, only works in the transverse plane. Everything with your wrist and hand will only work in the sagittal and frontal planes. So your wrist and hand do not have sagittal plane movements. They cannot rotate. All right, and then what type of joint is that? Yes, that's an ellipsoid joint. Now, what are the joints we have that go from our distal carpals to our metacarpal bones? Well, that's the type, but what's the actual joint? So yeah, there we go. The carpometacarpal joints, or your CMC. How much do those move in the fingers? How much does that move in the thumb? Yes, your thumb does have 2 degrees of freedom, but so does your fingers. Or actually, I take that back. Yes, the fingers do, but the CMC joint of the hand isn't going to do much moving there. So yeah, you're correct there. So thumb is our saddle joint. It's a CMC joint of the thumb there. Remember, the movements of the thumb are slightly different than everything else. So abduction, my thumb goes away from my hand. Adduction goes back towards it. flexion across the palm, extension, I go away. And then you have opposition and reposition. Now remember, reposition and adduction are the same thing. It's just your neutral movement. Don't confuse thumb flexion with opposition. So while they are similar in nature, what's the difference between the two? Yeah, so the thumb, when you are opposing, you're interacting with another finger. If you're flexing, you're just reaching across. So you would typically use thumb flexion when you're doing some kind of grip, like specifically like a cylindrical grip or a spherical grip. That's primarily where you'd see kind of that thumb flexion there. Probably a little bit also, yeah, with the fist grip too. So yeah, you could, I would consider that to be flexion. All right, and then all of our knuckles. So our first set of knuckles, what are those? So what are these? Yes, it's your MCP joint or your metacarpal phalangeal joint. So between your metacarpals and the phalanges or digits, that's where you're having your MCP joint. What type of joint is that? Yes, that is a condyle joint. And what movements does it do? Or I should say, do they do? Yeah, they're going to flex, extend, ab, and adduct. So they do have 2 degrees of freedom at the MCP joint. They're flexion, extension, ab, adduction. So again, only frontal and sagittal planes that I'm moving. When I'm talking about ab adduction, I'm doing relative to my middle finger. So if I spread my fingers apart, that is going to be abduction. So even though these two, index and pinky, are moving in opposite directions, they're both abducting relative to your middle finger. So I don't know what you would consider like the middle finger itself moving. I guess it's both abduction, either way it goes. All right, now what are my other 2 sets of knuckles? So what are my door knocking knuckles? Yeah, so your second set of knuckles, pip joint, the last or distal end, that is your dip joint. So proximal interphalangeal, distal interphalangeal. You're not going to be able to move, for the most part, the dip joint without getting the pip joint to move as well. Unless, again, you isolate it by cutting off the pip joint, and then you'll be able to move the dip on its own. All right, so those are all of our joints. Awesome. Now, for the muscles that we went over, remember the 3 big words, 3 big key words to help identify what that muscle does are carpi, digit, and pollicis. Carpi refers to what? The wrist, yes. And then digit, your fingers, and pollicis. Perfect. Thumb. Very good. Now, depending on where the muscle inserts is going to tell you where it shares a frontal plane movement with its antagonistic side. Meaning, wrist flexors and extensors are antagonistic of each other in a sagittal plane. However, your flexor carpi ulnaris and extensor carpi ulnaris are both going to share what movement? Yes, ulnar deviation. So even though they oppose each other in the sagittal plane, they're sharing a frontal plane movement. So the ulnaris or radialis is going to tell you what direction the frontal plane movement is. So again, same thing with flexor carpi radialis and extensor carpi radialis. Both are going to do radial deviation. So they're going to share that same frontal plane movement. All right, how are y'all feeling about all the kind of anatomy portions of this for the wrist and the hand? All right, so Matt is our designated spokesperson, I'm assuming. All right, now make sure you remember all the bones of your, or all your carpal bones. Carpal bones are named your metacarpals, and any of your digits are all numbered. So remember, thumb is 1, pinky's 5. Now, what I didn't specifically say with the radiocarpal joint is that it is going to be this right here. So you have your radius with the scaphoid and the lunate. So those are the 3 bones that make up the radiocarpal joint. Now, remember that your TFCC, this here is what makes it so the ulna doesn't actually touch your wrist. So this is why the ulna won't directly move the wrist or have any interaction with that. So all this here, that's all part of that TFCC. And this is a bit misleading because it has it so that it looks like the ulna is touching the lunate, and it doesn't. So yeah, this is a better representation here because you can see radius, lunate, scaphoid. Then you see the ulna, and you see you have this big gap here, relatively speaking. So this articular disc, that's again that TFCC. But you see how big that is compared to this here. What are these joints called? So what are all these joints? Well, they're not knuckles. Yeah, there we go. The intercarpal joints. And what kind of joints are they? So what kind of joints are your intercarpal joints? All right, so the intercarpal joints are your plane or gliding joints. And Ashley, I think you mean, or you mean to say a diarthrosis, which is correct. They are synovial joints. A diarthrosis joint just means that you are able to move. Plane joints essentially are like having two squares on top of each other and they can glide over each other. That's about it. And if you think about it, you're not really moving the wrist itself. Like, so the carpal bones themselves, that really isn't moving much at all. It's just really the kind of attachment site for everything else. All right, our norms. All right, so I want to kind of go over our injuries here. And then I think we will finish up with the carpal tunnel. Oops, don't want that. And we'll see, depending on how much time we have left, we'll maybe get into the hip here a little bit. All right. So with our dip joint, remember that this, again, is not going to really move typically by itself. I mean, yeah, you can have a bit of movement to it. So like I can do this with 2 fingers, kind of bend them just like that. But for the most part, you really can't move the dip joints unless you're using the pip joints as well. Because there's such an active insufficiency with these, they are pretty difficult to injure. I mean, how many of you have injured the tip of your finger in some way other than like stubbing it? I would assume probably very few of you. But again, remember that major impact you're going to have with this, or major injury risk, is getting hit square on. So you don't really have any kind of overuse type injury with it. You're going to get anything really as a traumatic injury. So here, same thing goes with the pip joint. The MCP joint, again, these are pretty much all going to be traumatic injuries if you were to hurt any of it. The only one really that we're looking at overuse would be if we had carpal tunnel syndrome. So we'll cover that here in a minute. All right, now remember with your finger muscles that the deeper the muscle is, the farther it controls. The more superficial the muscle is, the shorter it's able to control. So flexor digitorum superficialis, what is that going to do? Yes, that's going to do flexion of your pip joint. So that gives you your second knuckle movement. And again, superficial, so it is going to insert at and around the pip joint. And then profundus, what does this one do? Yeah, it's going to flex your dip joint. So deeper goes more distal, superficial is going to be proximal. And then as far as the distal wrist is concerned, all of your pronating and supinating muscles are going to say pronator or supinator in them. All right, we talked about the grips already. Remember that with your grips, your power grips are going to be for gross motor skills. Your precision grips are going to be for fine motor skills. A precision grip is going to have much fewer nerve to muscle fiber ratios than you will for something requiring like a power grip. So anything that you're doing fine motor skills with, you're going to have a lot less strength, but a lot more precision or a lot more ability to do the very fine movements. All right, and then we talked about the arches. Actually, did we finish up with the arches of the hand? Okay, so yeah, remember, same thing as the arches in your foot, except these aren't nearly as important because you don't weight bear on your hands. So it still helps with maintaining structure with them. But yeah, because you're not weight bearing on your hands, they're not nearly as important as say like the arches you have in your feet. All right, and now into the carpal tunnel. So again, remember, carpal tunnel has all these here. So 1, 2, 3, 4, 5, 6, 7, 8, 9. So we have 9 tendons going through there, plus your median nerve. So remember, your carpal tunnel is roughly about a quarter of the size of your wrist circumference. So like I said, when you measure your wrist, it's pretty much your middle finger to your thumb. So really, I mean, that's even a little bit big, but you get an idea, though. There we go, of just how little space there is. So you fit 10 things through a space that's even really smaller than this. What's not in the carpal tunnel? Yes, there's no muscle belly in there. That's correct. What else? Yeah, I mean, you're not going to have any bursa sacs in there, just because those would just be way too big. But the other thing you're missing here is any kind of ligaments. So the only soft tissue you have is from tendons going through. Now, all this kind of like grayish area, aside from the median nerve there, but all the other gray areas stuff there, that's all connective tissue. So remember though, you do have a carpal ligament that kind of forms the outer boundary to it. But inside the carpal tunnel itself, you only have tendons, a nerve, and connective tissue. Now, if you end up getting carpal tunnel syndrome, that's where you have some kind of inflammation in the area, but what's being affected is your median nerve. What is the median nerve going to control for us? Yeah, somewhat of digits 2 through 4. So your ulnar nerve, or I'm sorry, your ulnar nerve, your median nerve, that's going to control your middle finger completely. So that's digit 3. And then it's going to control the inner halves of digits 2 and 4. So it would essentially control the adduction ability of your index and ring fingers. What's going to control the abduction of your index finger and your thumb? So what allows you to do this? Well, you got to pick one there, Hector. Yes, it's going to be controlled by the radial nerve. And then pinky and the abducting function of the ring finger is going to be from the ulnar nerve. So remember, axillary nerve comes down your bicep, splits into 3 at the elbow. Radial nerve goes to your thumb side. Median nerve bisects the forearm. Ulnar nerve goes middle pinky side. Now, who is going to be the type of people that have carpal tunnel syndrome? And how did they get it? Desk jobs are one. And what's another big one? Yeah, manual laborers. And how do you get it? Yes, overuse or repetitive movements, absolutely. Anything where you go into wrist flexion is going to irritate the carpal tunnel. So, if you stayed like this all day or you're typing like this all day, even if you're typing and you have just even slightly flexed wrists, that's going to not be the best thing for you. To give the most amount of room to the carpal tunnel, you want to be in slight wrist extension. So if this here is neutral, you'd want your, you'd want your wrist to be round about here. So about 10-ish degrees of extension. That opens up the carpal tunnel more, so it gives you much more laxity in there. Doesn't cause any structural problems, but it will definitely help with allowing inflamed tissue in that area to get some relief if you're in that. So if you wear a wrist brace for carpal tunnel syndrome, you'll be in extension. And usually you have to get the thumb to stay either into an extension or a adducted or neutral position. You don't want to allow your thumb to go into flexion because that'll irritate it even more. I mean, if you even feel at your kind of wrist and you go over into flexion, you'll be able to feel where you have that contraction occurring. All right, so remember, any of these really bone issues here are all going to be a traumatic injury. I mean, there's really no way that this happens unless you have hurt yourself doing something. Now, this here, remember, is going to be bursitis. What are your bursa sacs? Yeah, so your bursa sacs are really fluid filled and they have like kind of that consistency of like snot. These are all around your more mobile joints, and they do provide like a cushion shock absorber similar to what you would have with cartilage, but they also provide lubrication to the underlying tissue. So specifically, they are going to lubricate your ligaments and tendons, and really specifically your tendons, so that they don't rub up against each other. If you get bursitis, those sacs become inflamed and hard. So this would feel essentially like almost like a baseball. I mean, I guess not quite as hard as a baseball. There'd be some give to it. Like if you had a mush ball, you know what those are? Where you can take like the ball and like squeeze it. That's what would be the consistency here. Now, your Little League elbow, your tennis elbow, these are going to be overuse injuries. If you have any inflammation in your medial elbow, what has caused that? What kind of force does that to you? Now, it's not going to be varus force. It's going to be valgus force. So varus would be if it essentially went inside. Valgus would be when it goes outside. So typically you're getting tennis elbow, little league elbow from an overhead motion. When you go from throwing, hitting from here to external rotation, the external rotation you have here creates that valgus stress on the UCL here, or at the medial epicondyle. Then going into internal rotation, that's where you're going to get that varus force. So more of the varus force would happen in tennis elbow, because really with tennis, you're not hitting overhead all that often. The majority of all of your return shots are going to be somewhere in this area. So when you have that internal rotation, which is more susceptible there for people playing people playing tennis, then that's where you're going to see more of that varus force. All right, so what kind of questions do you all have on the wrist and hand? All right, well, I'll take that as a good sign here. All right, so since we finished that early, I want to get at least started with the hip. So we'll go over kind of the basics of this here and then get right into it. So you are almost caught up. We are only about a class and a half behind. So I am quite pleased at all the progress you've all made. So slow clap, you all deserve it. All right, hip and pelvis, or you may see this as called like your hip complex or your pelvic girdle. All those are kind of interchangeable terms for this. Now with our hip, we actually have 6 bones in here, but we only have to worry about a couple of them. So remember, your pelvis is made up of 3 different bones: your ilium, your pubis, and then your ischium. I think they're just, oh yeah, ischium would be labeled down here somewhere. But the ilium is the most important to us because this provides most all of the kind of bony landmarks we're going to need for, say, measurements or any kind of reference points with the hip. So your ilium, that's the important one. Now, ilium is going to be up here. So roundabout belly button to the side, that's where you're going to feel the ilium. So that up there, that is really the top of your pelvis. The anterior superior iliac spine. So anterior side, which would be roughly right here. So if you follow that bone all the way around in front, that's where you have your ASIS, or that anterior superior iliac spine. That itself is really important because you're going to use that to measure things like, say, hip adduction and abduction. You're also going to use that as a marker for your Q angle. So yeah, quite important there. Your ischium is right under your butt. So right where your hamstrings meet your butt, that is where your ischium is. So if you're sitting down, you sit right on the ischium, which are these right here. And then the pubis or pubic bone, I mean, it's medially right around, really just superficial to, or yeah, not superficial, superior to your gonads. Now, those are the three bones that are fused together to make your pelvis. The other bone we want to know here is your femur. And then the other two we got here, sacrum and coccyx. Now, sacrum's 5 fused vertebrae together and coccyx is 2, but for all intents and purposes, they're each one bone. Your sacrum is going to attach really to the ilium almost exclusively to make up your SI joint or your sacroiliac joint. This is going to move a whopping 1 to 3 millimeters. And it really only does tilting. So just slight anterior posterior tilt. To give you an idea again of how thick that is, so this here, the width of this key, so I mean, you can see for reference how big that is, but the width of this key is 2 millimeters. So that is how much, like this amount of movement up and down, that's how much your SI joint actually moves. What's interesting about the SI joint is that it moves actually opposite of your pelvic tilt. So we'll talk about pelvic tilts here in a minute, but you'll see how it moves essentially opposite to what you would think it would. All right, so all those aside, our main joint is right here. So when you're talking about the hip proper, you're talking about the acetabular femoral joint. This is the actual ball and socket we have that make up the hip. You really can't palpate it. So when you're actually feeling around for it, your femur is going to be really right at pocket level. So wherever your pocket is, right in the middle of that, you'll feel that bulge out. That there is the greater trochanter of your femur. Now, this does share all of the same movements as the shoulder, but it's just going to be less. So the range of motion you have with the hip is less. And why is that? Well, it does have increased stability, but what does that actually mean? Or I should say, what does that actually look like here in the hip? It does have larger supportive muscles, but that's really not the big issue. All right, and what do you mean by prominent bony structures, Matt?
I guess I'm kind of looking at like the trochanters, like the greater and lesser. They look like They're just waiting to bump into stuff.
Right idea, wrong landmark. You're correct that having the additional bony stability is what is going to make the hip much more stable than the shoulder, but it's going to decrease its amount of motion. This is because the acetabulum is so deep that you actually fit that head of the femur well into there. So you see here, like this is stuck in there. And if you think about it, you know, how easy is it to dislocate a hip? Yeah, it's really difficult. I mean, you dislocate a shoulder, I mean, you might have sneezed wrong, kind of thing. I've actually seen people that just will pop their shoulder back into place and act like nothing happened. If your hip dislocates, you are going to the hospital. You are going to be in a world of hurt. Because remember, the more stable something is, and then it becomes unstable, you have to do a lot to get that out of there. Well, it's kind of like if you get stuck in, I don't know, something. Okay. Here we go. Something like this. I'm sure you've all seen something like some derivative of this where someone gets stuck in a swing or they try to get in a baby swing and then get like the fire department has to go cut them out or something like that. Well, how easy is it to actually get in this baby swing as an, you know, good size adult? Yeah, it's not the easiest. And you can see how it's even more difficult to get that out. So when you have that much stability, anytime you have a displacement or you have a loss of stability due to some sort of injury, it's going to be a major injury. You think about, like, say, your elbow, your hip, your ankle. If you dislocate those, like, you are in a world of hurt because those are, for the most part, pretty stable. Now, while it is possible to have really as much, if not more, range of motion in the hip than you do the shoulder, you know, that takes a lot of time to do that. So any one of you, unless you had some sort of like orthopedic impairment, could become contortionists if you really wanted to. Depending on your level of flexibility and your dedication to the craft is going to determine how much time it takes. But everyone can do that. The problem, though, is that when you create that kind of hyperlaxity, or you have that additional range of motion, you create inherent instability. So that's why you really don't want to do that with the hip. So people that are like contortionists, they tend to have early onset arthritis, and they use, I mean, how many, you know, kind of seniors, you know, older adults do you see that are doing, you know, circus performances kind of thing? Yeah, I mean, that doesn't really happen. So the more mobility you have, the more susceptible you are to overuse. So you don't want to take a stable joint and make it unstable just for the sake of having additional range of motion. If you reach the norms, so for example, with like hip flexion, and you shouldn't measure this standing up, you should measure it in supine, but gives you an idea. Hip flexion, if I can go to 120 degrees of hip flexion, that's all I need. That's about right to here. And if you think about it, do you ever have any need to raise your knee any farther than chest height? I mean, I guess if you're doing like the bow and arrow with your feet kind of thing, and you twist your feet over your head kind of thing, but no, I mean you really don't. So when we're looking at doing things like say flexibility, especially when you talk about like flexibility training, you want to be flexible to the point of function. You don't want to be overly flexible or hypermobile just for the sake of having additional range of motion. All right, so the acetabular femoral joint, that is a ball and socket joint. So how many degrees of freedom does that have? Yes, it'll have 3 degrees of freedom. So you can do flexion, extension. There we go, extension. I can do abduction, adduction, and then I can do internal and external rotation. Now, one of the other noteworthy things about this is what happens when you have your hip flexed to 90 degrees and your knees flexed. So if I take my, say, right leg here, and I move my lower leg laterally, what movement am I actually doing at the hip here? Yes, I'm doing internal rotation. If I move my lower leg inward, I'm doing external rotation. And this only works when you are referencing the lower leg of a flexed knee and a flexed hip. It'll go opposite of what the hip does. And it's just because the hip, when you have this 90-degree angle, or I guess any flexion for that matter, it's going to act as almost like a socket wrench. So you're going to turn the socket wrench one way, it's going to rotate the other way. So if I even hold on to my thigh and I move, you can feel how the thigh, and I guess even visualize how the thigh moves opposite of the direction that the lower leg is moving. So you're turning that crank there to get that. Now, when the knee is extended, then whatever direction the leg moves, that's the rotational direction you have. So if your knee is extended, meaning you're standing straight up, and I move my lower leg medially, that is still medial rotation or internal rotation with the hip. If I move it laterally, external rotation of the hip. Where are you going to have the most amount of range of motion for your hip? Yes, and flexion. Flexion, remember, is our position of deformity, meaning that our body reverts to flexion whenever essentially you have any kind of like neurological issue or whatnot. You think of like the fetal position, pretty much your entire body's in flexion there. So for the most part, there's a couple exceptions to it, but flexion almost always is going to be your greatest range of motion in a given joint movement. All right, and then the other big thing with the hip and why stability is much more needed with the hip here than say in the shoulder is the whole weight bearing bit. If you weren't weight bearing, you wouldn't need nearly the amount of stability you do. Because you are weight bearing, you need a lot of stability and you also need a lot of cushion in there. So you have several bursa sacs in the hip and you have a labrum in the hip. The labrum in your hip is analogous to the labrum you have in your shoulder. So the acetabular labrum and the glenoid labrum are analogous to each other. The acetabular labrum, much, much bigger. The other thing here is this. The outer margins of your acetabular labrum are vascularized. If you are vascularized, what does that mean? Yes, you have blood going to the area. And what does blood bring to the area? It does bring oxygen. What's the main class of things it brings, though? Nutrients. There you go. You can't heal yourself if you don't have nutrients. You can't get nutrients unless you have a blood supply. Does it kind of make sense why you would have a blood supply to the acetabular labrum? So because you are constantly weight bearing, whenever you're standing, and every step you take puts extra impact on the hip itself, you need to have those thicker cartilaginous support pieces here, and you need those to be able to heal themselves. Otherwise, this would like just continuously break down the more you used it. It's kind of like if you have a frayed labrum in your shoulder, you get that from throwing tons and tons of times. It's overuse. If we got those same overuse injuries to the hip, we wouldn't be essentially walking past like our teenage years kind of thing. Probably even less. All right, and then I don't want to get too deep into the, like say, muscles and other stuff here today since we're nearing the end here. But one thing I do want you to keep in mind here we go. is this right here. So again, greater trochanter of our femur is going to be a major functional landmark for us. So greater trochanter, again, this is right where you have at your pocket, that's sticking out is what you'll feel. So that is the actual site of the hip joint itself there. This also acts as a landmark for how our muscles function. Anything that is anterior to this, so if you're anterior to the greater trochanter, you are going to, in some capacity, do hip flexion. If you are posterior to the greater trochanter, you are going to do hip extension. So you're going to move that hip back. So that is your major landmark there. There's not really a definitive endpoint for where, say, like abduction, adduction is going to end. But in general, your abductors are going to be lateral muscles on your leg, the adductors medial on your leg there. All right, so again, hip, we are talking about the pelvis and the femur. Our hip joint itself is our acetabular femoral joint. The acetabular fossa from the pelvis and the head of the femur. Your hip has all the same movements as the shoulder, just to a lesser extent. So you can do flexion, extension, abduction, interlexural rotation. You can you can also do horizontal ab and adduction as well. So it does do that. So you can also circumduct your hip, meaning you can turn your hip into an actual circle. All right, so that covers really all the bony landmarks and really bony things we need to remember. So with only having about 10 minutes left, instead of getting into, like, say, the muscles and all that, I think we'll kind of put a pin in it for right now. But that's everything new I had for you there. So thank you all for getting through all that with me. If you all have any more questions, I will stick around until you all leave. If not, I will see you all back here on Wednesday.